Thank you all of you for joining us today. We're meeting Dr. Chu, who is an emergency room physician and founder of Ross Medical and Air Visits. He's going to tell us a little bit more about the ePatient concept and its key role in the future of healthcare. Thank you, Dr. Chu.
Thank you very much, Marcus.
So tell us, Dr. Chu, what is the ePatient?
Well, the ePatient is a concept that we came up with a few years ago. It is the combination of inpatient care and outpatient care. It takes all the benefits of what inpatient or hospital level care is, such as monitoring and assignment of medical providers, with the freedom and the choice of outpatient care, as well as the cost reduction, a lot of the benefits of outpatient care. Where as an in-between, we wear a lot of the types of equipment, the same equipment that you would as an inpatient, and the assignment, and you have the same kind of medical workup, except you don't have to be in your bed or in that hospital bed anymore. You could be in your own bed, at home, going to your own cardiologist, your own doctors, outside.
Whoa. That sounds a little unsafe to me.
I mean, this is one of the dichotomies of medicine. So there is a spectrum of safety beyond for patient care. So if you're just like you and me now, we're at a risk level where we can be managed as an outpatient. I can go see my own doctor, and in 2 months you can see your doctor next month. We're not having heart attacks right now, but if we're having a heart attack, we need to be within the walls of the hospital. We need to be taken care of there. But there are varying gradations of levels of risk of patients. And right now, there's only two places that you can be treated. You're either inside the hospital or you're out. But if you just barely cross over the threshold, you're in this gray area. And that gray area is where the ePatient comes into play.
Okay, so tell me, how is ePatient going to change the healthcare experience?
Well, right now, if you say have chest pain, like what we were just talking about, you would come to probably one of the emergency departments like mine, and you would get blood work, an EKG, a chest X-ray, and we figure out, well, are you at risk of having a heart attack right now, or are you actually having a heart attack right now? And normally, if you were low risk, the tests that are in the ER are not enough. You need to have more tests. You need to have more monitoring. So normally, right now, you would actually be admitted to the hospital or stay in an observation unit for the next 2 days on average. An ePatient doesn't have that second step of the admission. The second step of that admission within the hospital is done outside the hospital. So instead of staying there, you would leave the ER after maybe 2 hours. You'd be wearing monitoring equipment, you have doctors assigned to you, and then you'd be able to get that care except outside of the hospital, being monitored, GPS tracked, having 911 have a constant finger on you to make sure that you're safe enough while you have the convenience of being at home, talking to your own cardiologist, following up with your own doctor, and being in your own bed, away from the hospital-acquired infections.
Okay, so I can definitely see how, as a patient, I would like the flexibility not to be in the confines of a hospital, but you're telling me that there is still the required monitoring should I need immediate care outside of the hospital.
Absolutely.
Okay, terrific. And I can understand the benefit to the patient of ePatient itself. How would that affect hospitals? Because it would appear to me that rather than having people in the confines of a hospital, which I assume is how hospitals make money, they're leaving. Isn't that a detriment to the cost basis for a hospital?
Actually, we select a lot of the patients for ePatients based on how the hospitals are able to manage them. So for patients that are very high risk, the ones that are actually having a real heart attack, those patients actually can stay within the hospital, and hospitals make a lot of money on them. But the way the healthcare structure is structured right now in the current state is that right now hospitals do not get paid enough for those type of gray area patients, the ones that go into the hospital. And by taking them off their hands, the hospitals can actually save money. We take away the cost loss patients from the hospital so they can save money. And that profile is actually very different for different types of hospitals. But we work with every single hospital to make sure that they can save with each type of patient that we bring onto the ePatient system.
Okay, so it would appear then that the ePatient allows care for those that do not have the acuity to be in a hospital, but are agile enough to be outside and be monitored, is what it sounds like to me.
Yes.
Okay.
Yes, there is, and traditionally those patients, since there is only two places that they could get care, either as an inpatient or outpatient, and the only one of those enables monitoring, management, higher level testing, all those gray area patients are traditionally admitted or kept in the hospital under observation, accruing all those same exact costs, whereas those gray area patients we take care of now.
And what is the impact of ePatient on risk management to insurance companies and the cost to insurance companies?
Right, so inherently the ePatient has a lower cost threshold. The ePatient level of care uses control centers, call centers to be able to manage a lot of the patients. It lacks the brick and mortar of a hospital system and doesn't have to pay for the brick and mortar of a hospital system. So inherently, the cost of ePatient care is so much lower than inpatient care that the charges to insurance carriers and payers and ultimately the beneficiaries is a lot less than what inpatient care would be like with hospitals that demand a higher level of payment for the high level cost that it is for patients to stay within the hospital.
What about risk management to the insurers?
Right, so the risk management profile is the same as that of the physician. There is no different of what the risk of the patient is and the risk of what the physicians have. So payers want to make sure that those heart attacks or those chest pains do not progress into something worse, congestive heart failure or other types of poor diseases that are very costly. Same thing with the physician. They want to do what's best for the patient. They don't want those conditions to progress on to something else that is worse or have poor sequelae. At the same time, they both want to give that level of care and work up those patients in an appropriate way in the most efficient way that they can. So what the ePatient offers is it takes that gray level of patient, the one that has very low risk, and is able to even further reduce that risk by giving the same level of care, but also taking them out of the hospital where they do not acquire MRSA or other types of hospital-acquired infections.
Okay. And will the evolution of ePatient require caregivers to assume some new skills and become more technologically savvy, or what is the impact of ePatient on the caregiver themselves?
Right, there is some learning. We can't lie about that. There is some learning on the mid-level staff level, so the nurses and the care providers, and also the capabilities of what the ePatient can do for physicians as well. There's also learning on the hospital side and the administrative side to say that this is another operational modality for them to use when there is bed crowding. And it is almost another type of care that is not traditionally taught in medical school, but is more of an operational type of care, where as physicians learn how to deliver care remotely to patients and learn about the thresholds of when to bring patients back to in-person care or repatriate them back to in-person care, they're able to practice this a lot better. But we provide training programs for all of the other providers that use our service.
Okay. What about the capital outlay hospitals have to go through to acquire this technology? Why not talk us through some of that?
Right. So actually, there is very little capital that a hospital would have to put up front at all for any of this. They're not the payers for it. Actually, the insurers are usually the payers. There are other systems where hospitals and insurers are in one, but they don't have to pay for this. Just by admitting a patient to the ePatient-like service, the ePatient service, we provide all of the equipment directly to the patient, and we bill health insurance the same way. It's almost like transferring the care from one hospital to another, where there is no money exchange in a transfer of care. It is just transfer of the responsibility, where the new facility, the ePatient facility, the virtual facility, would bill the insurance companies directly, except at a fraction of the cost.
Wow. Sounds very exciting. Well, thank you so much for your time, Dr. Chu, and thank you to listeners for joining us today. If you'd like to learn more about ePatient, please go to rossmedco.com. Thank you.
Thank you. Thank you very much, Marcus.
Thank you.